Good morning, and it's a pleasure to be with you, and thank you for inviting me to present on the impact of new COVID-19 variants and the vaccine rollout on the pandemic. I will briefly talk about excess mortality, which is very important as we measure the impact of COVID-19, then move very quick to COVID-19 projections, tell you briefly how we do the projections, talk a little bit about the new variants and their impact on the pandemic, of course, the rollout of the vaccine and the impact on pandemic, and then briefly provide a summary at the end of my presentation. As you all know, we do at IHME the global burden of disease, where we provide what are the causes of death and also the risk factors attributing to death and injuries. And in order to do so for GBD 2020, we have to get accurately how many COVID-19 cases have been, how much mortality, and of course to get a disability weight around it. So it's very important for us not to take the deaths that have been reported, but to capture all the deaths that have happened during the COVID-19 pandemic all over the country. And what I'm showing you a couple of slides here is work in progress. We haven't finalized it right now, but we have about 50 or 60 countries where we have good data about how many cases and how many deaths from COVID-19 have been reported. And we have actually the death records that we can even look at them and see how much COVID-19 was underreported mortality. And of course, our assumption here that COVID-19 mortality was more likely to happen and be underreported early on during the pandemic, because of course, as you know, when the first wave hit, people who were more at a high risk, they didn't know that COVID-19 is circulating, and unfortunately, none of us was wearing a mask at that time, so we would have much more deaths, especially like among the vulnerable population. We've seen it in many countries and nursing homes. This is what we are looking at right now. We see a lot of excess mortality in many parts of Africa, many parts of Asia, to lesser extent in the United States and in Europe. And Russia has a good reporting system, but still there is excess mortality in every country in the world. And there have been some studies showing that there are excess mortality that have not been reported. Indonesia, for example, you have a high unreported deaths of COVID-19. And in our early analysis right now, we're seeing a huge difference between what has been reported in deaths of COVID-19 and what has actually occurred. And to give you an idea, this is by different regions in the world, and you could see the total number of deaths that have been reported. We're about 2 million deaths right now, 2.4 million deaths. You could see here that we have much more higher number of deaths right now, maybe threefold when it comes to COVID-19. And to simply look at it in some of the countries, take for example the United States, with about less right now than 500,000 deaths in the US. We're estimating about 716,000 deaths in the United States. So in a country like ours, where we have good vital registration, we have underreported deaths from COVID-19, and you have seen that CDC reported last year COVID-19 2020 was the third leading cause of death. So of course, it's a high level of mortality, but also underreported, especially early on, because we were not doing enough testing in many countries in the world. Let me now move briefly to talk about our COVID-19 projections. And some of you who have seen me presenting to this group may have seen some of these slides, but I want to briefly tell you how we do it, because it has a lot of implication on what I'm going to present on the impact of COVID-19 vaccines and new variants of COVID-19 pandemic. COVID-19 projections at IHME started at the request of our medical center, UW Medicine, and they wanted to know how many beds they need to prepare, how many ventilators and ICU. And as all of you remember, in the United States, the first case was diagnosed here, first death was diagnosed here in Seattle, in our catchment area. And we had a lot of deaths early on in the nursing homes here. And we started doing this at their request, doing it for King County and Snohomish County, where Seattle is. and the rest of the state, and we started doing it for every country in the world. And that's very important. When we do this for every country in the world, we could see patterns, and we were able, for example, to predict in the US a surge this winter, last winter, because we have seen a surge in winter in Argentina, in the southern hemisphere, where cases kept going up, even with all the measures put in place, strict social distancing mandate and high level of mask wearing. So we looked at the association, why winter? And of course, we determined that it is a seasonal virus and it's acting up more in winter, like pneumonia, not like flu, like pneumonia, because pneumonia doesn't go down totally in summer. And we've had surges from COVID-19 in summer. Right now, a surge in summer from COVID-19 in Brazil, for example, in their summer. And our model has evolved. Right now, we're in the third version of our model. Briefly, our model takes uh, early on, let me say it, early on, we did not use the susceptible, exposed, infected, and removed model, SEIR models, because we didn't have lots of testing, so we didn't know how many people have been infected. So we used mortality and we used a curve fit, and we backward from mortality to infection and need for hospitalization bed, etc. So we looked for each death, how many hospitalization have been, and then we counted the deaths and we went backward, and then we projected the deaths all the way up. And that model did extremely well in predicting the peak, but failed in predicting the decline simply in the United States. At that time, it was building its priors on the experience we have seen in China, Italy, and Spain and South Korea, where the pandemic went up and came down symmetric epidemic curve. It wasn't true in the US simply because we had premature opening in the United States, so we had a bumpy decline, and then we had to shift all these models. Right now, the SEIR model and random knots that we do in order to get the curve, we use in our model several variables, mask use, we use cell phone mobility data. Now we don't have to use only mandate, which we use in our model, but we know mobility. So we know the impact of a mandate on a mobility, whereas in the previous model, in the early model, we assumed a mandate will have the same effect everywhere. We know that's not true right now. Different mandate in different states or different locations have contributed to less decrease in mobility sometimes. And we have data on that. Pneumonia seasonality testing, of course, particulate matter, because this is a lung disease, altitude, and of course, pneumonia death rate. And all what I'm presenting when it comes to the COVID-19 is available on our web. We have a COVID-19 projections. We put our articles out there, scientific articles, our policy brief, frequently asked questions, and you can download the estimates. And all the data is available on covidhealth.org. healthdata.org. Just to give you an idea, this is a good example where California, for example, where we have good data in many states here, and it's a large state, the largest state in the United States. But you still see how much variation from day to day when it comes to the data. If you're looking at cases here, green, hospitalization, blue, and red deaths, you could see how noisy the data is. And we have a weekend effect, we have a holiday effect. Right now, after Easter, we have a holiday effect. We have less reported death cases on Saturday and Sunday, and on Monday, sometimes on Tuesday, and it picks up towards the end of the week, then starts coming down. And hospitalization is the same way. So we have to do a lot of work in order to clean the data and smooth the data. Imagine a smaller state in the US, and imagine countries where also they don't have as good reporting system like we have here in the United States. Hospitalization is good in the United States because hospitals have electronic reporting, but again, there are disparities in remote area where the hospitals do not have that capacity. So there is a huge variation, of course, between one state to another. We also at vaccine hesitancy, and we have a huge problem, large problem when it comes to vaccine hesitancy, even in the United States, where we have about 25% of Americans are telling us we will not take the vaccine, and about 75%, it varies by state, are saying we will take the vaccine or we are considering to take the vaccine. Yes, I may take it. And we have people who say, no, may not take it, and no, I will not take it for sure. So we monitor all of this because it's very important in our projection. And of course, we monitor the supply of the vaccine, how many vaccines we're going to receive, how many vaccines each country has secured, and when they were received and promised by the pharmaceutical companies. We also monitor how percentage of people infected, and that's very important. And you will see later on in the presentation why it's very important. So how many people have been infected? And we have seroprevalence surveys that we use. And right now we know that antibodies will decline with time. So I'll talk a little bit how we're trying to adjust for that. But it's very important for all of us to know how many people have been infected when you look at herd immunity, because it's very important to know infected plus vaccinated, so you know where you are, where you stand in terms of herd immunity. And here, for example, if you look at what's happening in South Africa, for example, and in Brazil, where we have a lot of locations in Brazil where the infection is over 50%. In Amazonas, for example, in Monash, 60% infected. Still, they have an outbreak when they have the new variant, the P1, P2 variant that came later on. So keeping an eye on what the percentage of infected people in each country from seroprevalence survey is very important, and we do that at IHME. Let me talk about the new variants and the complexity of working with the new variants, and I'll briefly do that, and I'll present on the impact on global. We have of these analysis with seeking more data, and I'll tell you why it has been a little bit of challenge, but we have some ideas of where we are heading and what the impact of the variants and vaccines on the pandemic. So if you look, I'm just giving you examples here. If you look, for example, take an example from Nigeria, blood bank studies show that they have high seroprevalence, but at the same time, we don't have many cases being reported, and there is a low A-standardized infection fatality rate. So it's contradictory here. One is telling you there have been a lot of infection, but people are not dying from it, and there is underreporting of this. And even in good places where we have good data in Nigeria, they don't add up. So something is happening there. Just I'm giving you an idea. Waning sensitivity of the antibodies test. So one of it, the test sensitivity is coming in decline, and it varies by the test. And also, depending on when you test, there is a decline in antibodies. So you don't know what's the true percentage of infection, because it depends on the decline of antibodies and when you do your test in the blood. So, and previously infected individual makes a little bit more complicated in the analysis, because if the previous infection, and we have seen that right now, the good example I gave you is briefly in Brazil and in South Africa, where the infection was very high, and when a new variant in South Africa, B1351, showed up, and the P1 in Brazil, and later the P2, we still see outbreak in highly infected, previously infected people, even from seroprevalence surveys. So if you take in Monash was 60%, and we've seen outbreak and death. So here is the question: is the new variant does not provide immunity? So previous infection does not provide immunity against the new variant. So that's one. Two, the new variant makes the vaccine less effective. So that's another thing that you want to take into account. Is the new variant more likely to spread faster and increase infection, or the fact that the new variant, there is no cross immunity, it's going to infect, as we have started a new epidemic in that location? So these two, we don't know which one is taking over. Is it the fact that you don't have immunity simply from previous infection to this new one, or is the new one more likely to be infectious and it will spread faster? And finding that balance takes a lot of analysis, and we need data to be able to compare it. So there's so many questions here that we need to get right in order to make sure what we are seeing is a true increase in infection. Is it the fact that there is no immunity before to this new variant, or is it the combination of the two? So we use, for example, GIS-AID, where everybody put in it once they do a genomic surveillance of their circulating COVID-19. And then also it's underreported. So for example, the Minister of Health in Turkey Turkey, I don't speak Turkish, but tweeted that they have 40,000 cases of B1117 that they identified. We didn't see it on GIS data. So there are a lot of information out there that sometimes high officials, who know what they are doing, come up and say it, and we don't have the data on it. So sometimes it's very hard to get credible estimates in many places, and there is a delay between sequencing and reporting. So we looked also, in addition to the GIS AID data, we look at how close countries are to each other. So when it's circulating in South Africa and has been picked up, so we give more validity to somebody next door to South Africa to say, oh, I've detected B1351. Same here in the US. If we find it circulating in one state, we say, okay, that's more credible. That's now circulating in the next door state, and so on. So it's very important to do that. Now, our colleagues in England have done a very good job. By the way, many countries do more genomic sequencing than we do here in the United States. We still are not doing enough to know what's circulating here. And right now in the United States, if you look at CDC webpage, the variant that they are keeping an eye on, for example, is the 2.1 in California, 2.1 in New York, the B1351, B117, and the P1, P2 from Brazil. But for example, California announced 3 days ago they have detected the new variant that came from India, and it's a combination of what was circulating in California and the P1, P2, or B1351. So it has a combination of the escape variants that we have seen in South Africa and in Brazil. So there is not enough testing. But in the UK, they've done a lot of testing, and also they've done follow-up. We know, for example, when B117 was introduced, what was circulating, and they followed up that. So we know how, when B117 came into play, how did it react or interact with other variants, and which one became the most dominant, and how it moved throughout the time. So that has helped us a lot. And in many European countries, when B117 spread, how it moved faster was in these countries. So we have more information about B117 than we do have about B1351 or P1, simply because of the history. It happened. B117 started in the UK where they're doing a lot of testing, whereas the P1, P2 started in Brazil where they're not doing enough of genomic surveillance. So that has a lot of consequences on what I will be presenting. And we track these variants. So if you look like now on our webpage, you'll see the prevalence of these circulating variants all over the world. So of course, B117 is the most circulating one in Europe, Middle East, and now in the United States. It's the most dominant one in the United States right now. Why B117? What we have seen in Europe, when it came about, it basically overwhelmed all the other mutations, so it took over, and then it's the one that's spreading. So it's suppressing others one spread, and at its expenses, it's spreading much faster and taking over in many countries where it is. And the B1351 is spreading in Africa and certain parts in Asia right now. It arrived to Europe, less so in the United States in terms to take hold, but we have been detecting B1351 in many states in the US. But in our models, unless we get 5 locally, we don't start the counting all the way up. We say it's not yet circulating and it's imported. And then once we detect 5, then we'll take it to another level and we start the spread in that location. And I'll tell you how we do it. And of course, the P1, P2 started in Brazil. It's all over South America. And now, unexpectedly, it's in Florida and the Northeast. And because of the relation, of course, Miami Airport and going to South America. So we have a lot of data right now. There is a reduced cross-variant immunity, and I'm trying to explain these before I go into the model. So we know, for example, in Novavax trial in South Africa, and their placebo arm, there was 3.9% in COVID antibodies positive and negative. So basically, in their control arm, they had people who were seronegative, and there were people who were seropositive. So there were people who were infected, people who were not infected. But still, the B1351, the attack rate or the infection rate was 3.9% in both groups. So previous prevalence didn't protect, so there is no cross-immunity from the previous one. The AstraZeneca trial showed that there is a reduction, but there is about 37%, not 100%, 37% protection against the new variants in South Africa once you have been infected before. So 0 to 37%, with the confidence interval to be 0 to 50%, or none, of course. So that's very important to keep that in mind. And then when you look at the surge in Amazonas and Monash in Peru, in many locations where I have showed you the infection is very high, that tells you there is no cross variant immunity. So these are escape variants. They're not. They don't have. We don't have immunity against them if we've been infected before. And of course, if there is a profound decline in cross immunity, then there is unlikelihood immunity will be harder to get, and that's very important. But the concern here is not only that the new variants, we don't have immunity against them, cross immunity. The concern here is they will make the vaccines less effective. So we have published this, and there have been a lot of studies since this, so there's some updates to this one. But let me tell you what we had before, and now I can show you some of I can tell you as we go through it what the difference are from our estimate and what we have found in real life. So for example, you've known Pfizer and Moderna, they said 95% effective, 94% effective against preventing disease. That's very important. The way effectiveness was set is preventing disease. But preventing infection is totally different. So we assigned 86 and 85. Right now we know, for example, for Moderna, the new study that came out, it was 90% effective against infection. We had 86% with a confidence interval around it from our own analysis here. And when you look at all these vaccines, so take AstraZeneca, for example, and I want to focus on AstraZeneca because it's the vaccine that COVAX has bought the most of it, and it's the most one that will be used in many countries in the world. So US bought 300 million AstraZeneca vaccine, but it's not authorized here. And you've heard President Biden said we want to give it to Canada and Mexico. So if you look at AstraZeneca, it's 74%, and we don't know 74%. There have been a lot of issues with the clinical trial for AstraZeneca. 74%, we know it's 52% when it comes to preventing infection. But the scary part, and it was published in Lancet, that AstraZeneca is 10% effective against preventing B1351, and you've heard that South Africa stopped it for a while, and they have stopped it right now. But it's 9% preventing infection from B1351. So these vaccines, all of them, including Pfizer and Moderna, have less effectiveness, about 72%, against the new variant, the escape variant, the P1, the B1351, and less than that, 62% in preventing infection. So still highly effective for a vaccine. We take above 50%, but again, keep in mind that these vaccines with new variants coming up that are escape variant, they're less likely to be effective, especially if there is no cross immunity. So why would the vaccine be also better? So it will decline, its effectiveness will decline. So keeping that in mind is very important in what we do. So now the hardest part is estimating past infection. And because in order for us to build a model and say what's the impact of the new variant and the vaccine, we need to know how many people have been infected in the past. And of course, there was no zero prevalence surveys early on. We're doing it right now. We're catching what people are, what their seroprevalence at the time, cross-sectional survey, except for some European countries who are doing follow-up, and some of the clinical trials are testing people right now to see the declining in antibodies as they've been monitoring their people who have been in their clinical trial. But you could now look at it as the increase in, for example, it's very hard to look at the past, but it's the increased transmission, for example, in South Africa or Amazonas, is due to the combination of increased transmissibility of the variant and reduced cross-variant immunity, or something else. So that's the difficult for us to go and do it. And the combination between the two is very hard. And we're using the experience and some assumptions that what we have seen in Europe. So let me briefly say that. So what we're doing right now in order to do this long range projection, I'll show you very long range projections that we haven't released, but this is a scientific presentation here. So we're assuming as people get vaccinated, and we have survey data that's telling us that when people are receiving their vaccine, they're telling us 25% of them are telling us in the United States they will not be wearing a mask. And you've seen the relaxation in the United states like Texas saying no more mask mandates, we would expect that that there'll be decline in mask wearing, especially this summer, since the cases are coming down. And you're telling people be vigilant, but they look around, cases are coming down, hospitalizations coming down, deaths is coming down. It's spring, it's summer, so very hot. So we're saying we have different scenarios in our projection that mask wearing will decline this summer. It goes up again in winter, and I'll give you some scenarios. It will remain constant, so people who are wearing a mask will keep wearing a mask. Some of them will drop it. There is a seasonal mask wearing where in winter all of us will come back to the mask simply because cases are going up, and then we could provide a scale up all the way to 95% in places where the infection is very high. So we assume countries where infection is very high, put the mandate, will hit the brakes and say, put the mask. Vaccine confidence, we're assuming that people who are saying probably yes will take the vaccine. So one of our scenarios. And we're saying even people who may say probably I will not take it, we may be able to convince them to get the vaccine. So instead of right now it's about 70%, we'll say maybe it's more than 70% of Americans will be taking the vaccine, simply because those who told us probably not, about 7 or 8%, they will take the vaccine. And mobility, again, we're assuming in July, and I'm talking about the US, but it varies, of course, by country depending on the summer. On July 1st, we'll go back to mobility like what we were doing before, because things would be very good. Or we can return to where we are in May 1st, and then we'll hold it all the way up. And we know from our data, for example, before the mandates were imposed, when we got the mobility data, we know that people, even before there was any mandate in the United States, they stayed at home and mobility declined. So we know that certain segment of the population will be very careful unless it's all clear they will not relax in terms of mobility and mask wearing, and we take that into account. So here, the other thing about the cross-variant immunity, because we've seen 37 and 0, Novavax 37% in AstraZeneca, we said it could be 0 to 50%, these escape variant. Or for some variants, it's 50 to 100%. So there is a cross immunity. We are entering in our models that will have a booster that will address the decline in vaccine that I showed you effectiveness. So, and we know Pfizer, Moderna, everybody, even AstraZeneca is now modifying their vaccine to be, to be able to be more effective against the new variant. So that's very important. So we're taking that into account, and we've been asked also to add in our projections, which I'm not showing you today, that the vaccination will be declined, will be lowered, the authorization to age 12 and above. And of course, we're talking about variant speed, slow and fast. We'll give different scenarios for that, because some of the variant speed, we know B117 is very fast. Some of the variant speed is much lower, although they are escape variant like P1 and P2. We haven't seen them spread as fast as what we have seen spreading with B117. So basically B117, that's spreading so fast and not allowing others to spread in a way. We have so many evils fighting, but the evil that's winning, the lesser evil is winning in a way. That's how I look at it sometimes. That B117 is winning, and there is no winning here, but is overtaking, and we know the vaccines are much more effective against it, and it has some cross immunity from previous infection. So let me show you briefly some of our long range, and I'll take some time to explain it here. So this is global. This is the whole world, and what you're looking at here is the line is previously what has been happening and in terms of daily infections and daily deaths. And in daily infections, the green one that is showing you before you have all the options is what our estimate of real infection. And the lower one is what has been reported in infection. Remember, every country underreport, and we have a percent detection rate that we use for every country in order to do that from seroprevalence survey. So look at seroprevalence survey and say, oh, you have 20% people infected, you said 1% infected. So there is a factor of 20 here that you're not able to catch. And we add it for every country in the world. So some of the scenarios is very pessimistic here, that the cases will increase, and then we will have another wave, and daily deaths could go up about to 30,000 deaths globally a day, one of the worst case scenarios sometimes in 2022 at the beginning of the year, which is the European Northern Hemisphere winter. And let me talk about high acceptance of the vaccine will be a little bit lower. A booster will be the blue, so the mortality will decline, as you can see, especially in during the winter. The mortality with vaccine and a booster will be less or similar to what we have seen in the mortality in December and January of 2020 and 2021. So that will help. High acceptance of the vaccine and the booster, so increasing allowing the people who say I may not take the vaccine, maybe not, to come in. So that's what high expectancy is. We say everybody who says probably not will add them. So high expectancy and a booster vaccine will be much lower than what we have seen in the previous winter. So basically for the US, for many countries in the world, we have high acceptance of the vaccine, and we could have a booster that we can develop before we hit winter. We could be, the mortality will never reach what it has reached in last December and January, and that's very important. And low mobility, look at low mobility, and the regular vaccination is way lower than what we have seen before. So it's very, even infection much lower than what we have seen before. And it's very important. It's mobility. If people behave and stay at home, and then especially during winter, that will reduce the infection, as you can see here, and will reduce the mortality. Of course, with the vaccination, that will help us a lot in the United States. If we do masks are the most effective tool we have right now. Not everybody has access to a vaccine right now, but all of us have an access to a mask. So it's very important. Mask wearing is very important. If we continue mask wearing at 95%, cases will be declining all the way till our winter in the Northern Hemisphere and in the United States. It may go up a little bit, but never to what we have seen before. And mortality will go up a little bit, but not as much as we have seen before. And then the most optimistic we're hoping for is all the good ones are done in terms of vaccines. Everybody take the vaccine, everybody take the booster. Everybody who said I will take it will take it. We keep mobility low. We keep mask wearing very high. This pandemic will start declining from now on all the way in the world, and then we will not have a big bump next winter in the Northern Hemisphere. But you see here, July, you see that jump in July, that's the winter in the Southern Hemisphere, which is, you will see a little bit of a rise there, and it will be an increase. Mortality will increase a little bit to what we have seen in our winter in the Northern Hemisphere. We'll see it for the Southern Hemisphere, but it starts coming down after that, if again and again we do a very good job on controlling this virus. So these are the scenarios we're looking at. So let me break them now by one, same as above, but let me break them down one by one to look at them, the impact. So if you look at global vaccine scenarios, assuming mobility return to pre-COVID-19 baseline in July, and mask use return to zero on July 1st, cross variant is 0.5, transmission escape variance is 0 to 50% of B117. And these are the scenarios here. You see the reference scenario, what we're saying will happen. Low hesitancy against the vaccine, booster, and low hesitancy plus booster. I mean, vaccines will play a big role on their own here, if holding everything constant. If we are accepting the vaccine and we take the vaccine. I mean, vaccines are our only hope to get out of this pandemic, is to accept the vaccine and take the vaccine on time. Now let me look at mask use. Mask, as I keep insisting here and keep reminding all of us, that it's very important to reduce the spread of the virus, simply because of the lack of vaccines. We don't have vaccines for everybody right now. So if you look at flat mask, again, if you keep the mask at what we are right now, keep it flat, cases will keep down. You'll see a bump in July, especially in the Southern Hemisphere, but it will come down. We'll see a rise here in the United States, simply because of our seasonality around the new year, a little bit delayed simply because of the mask. But if we have a seasonal mask and we wear the mask, it's not as good as the flat mask. If we drop it and wear it, no, if we continue doing it, it's much better. The green is much better than the seasonal mask wearing here. And the best scenario scenario, if we keep the vaccine at a higher level, yes, we'll have a little bit up. We can control the pandemic everywhere. It may go up in Northern America simply. You don't see it here going up in southern global in the southern hemisphere, but you see it going up in the northern hemisphere because we're assuming right now for the northern they have a good summer. They will, even if the best case scenario of their mask would not be as vigilant as if they didn't have that big surge. So let me summarize here. So impact of new variants and the vaccine. Vaccines are our only way out of the COVID-19 and taking the vaccine. I mean, that's a given. I don't have even to discuss that. But I hope people will hesitancy, we can address it and make sure we go to community, whatever the source of this hesitancy, and make sure people take the vaccine. Case and deaths will increase due to new variants. In the United States, we've seen that it increased a little bit. We've seen that bump in the road, and it will come down. And so cases and deaths, we said, with the new variant, B117 cases will increase, and this will, and we've seen it in some states right now. On the national level, California, because they had it locked down, we didn't see a decrease in national. We've seen a bump in the road, but it's coming down in the US. But in many countries right now, we will see a rise in cases simply because of the variant B117 in Pakistan and Bangladesh. In many countries in the Middle East, we're seeing a rise of cases, and P1, of course. So we'll see a rise of cases unless we are more vigilant. Mobility, seasonal mask, and vaccines will reduce the spread. So if we reduce our mobility and seasonality right now in the Northern Hemisphere will help us. Mask use will help us, and vaccine. Vaccine hesitancy is a big concern, and I'm concerned about AstraZeneca. We've noticed in the US when AstraZeneca was pulled off the market in Europe, we had a slow, I mean, not much, but we have a little decline in vaccine acceptance. So vaccine hesitancy was about 25% of Americans said they will not take the vaccine. 20% of Americans were saying, "No, I don't want to take the vaccine." In certain locations, it increased a little bit. So in the US, it was 74% of Americans say, "I will take the vaccine." It went down to about 70%. So we've seen a variation by state simply because the news of AstraZeneca, although we don't have AstraZeneca, it's not authorized in the United States. So I'm concerned with AstraZeneca. If it has a low effectiveness against P1 and B1351, and we're giving the vaccine, it will create a hesitancy, especially when we have a better vaccine coming up or AstraZeneca modifies its vaccine. So that creates a problem for us. We need a booster for sure. And I know many companies are working on a booster right now, pharmaceutical company. And all of us are tired of COVID-19. I mean, people want to go out and start. We're seeing an increase in mobility and the economy. I mean, the economy in many countries are hit so hard, so they want to open the business, and that balance is delicate and fragile and very difficult. So that's a big challenge as we move. From a population health perspective, let's prepare for the worst, and hopefully it will never happen. So let's say in the United States, let's plan that this virus will be with us on a regular basis for a while now. Let's plan annually. We need to get a vaccine. We need to stay ahead of the variants. We need to have that vaccine that takes into account what's circulating in the US, what's circulating elsewhere. So we need to do genomic surveillance here to find out what's circulating in our backyard, but also what's circulating elsewhere, and then keep improving our vaccine, not improving, but making them attack the new virus, like we do with flu every year. We tweak the flu vaccine to make sure we're up to date on what flu strain is circulating and mutation is circulating. So that's the only way we can stay ahead of this virus. This is all what I have. Thank you very much. This is my email. If you have any questions, the presentation will be available, of course, the slide for everybody else. Once we finalize the excess mortality and the long-term projections, we will release them, but I wanted to share with you what we're coming with, what we're dealing with, and how we are trying to deal with it as we move forward. And I joined the Twitter, and I put some of this information on Twitter as well, so which is for my generation. This is a big jump for me to join the social media and do that. So thank you very much, everybody. Thank you. It was a pleasure talking to you.